We would like to invite Dr. Rakshya PANTA for her topic on congenital glaucoma.
It was in this my pen drive. I've given it in the morning also. Congenital glaucoma. Good afternoon, everyone. Today I'm going to talk about primary congenital glaucoma and my experience with it. So coming on to I have no conflict of interest, or all photographs was taken with consent from the patient's family. So coming to the introduction, as we all know, primary congenital glaucoma is isolated maldevelopment of trabecular meshwork not associated with any other developmental anomalies of the eye that could raise the intraocular pressure. So Barkan, he proposed that there is a persistent fetal membrane that is overlying the trabecular meshwork that is responsible for the glaucoma. So it is, as we all know, it's a rare eye disease. The worldwide prevalence is around 0.01 to 0.04%. However, the incidence is very different in different populations. As we can see in the Western data, it will be as low as 1 in 10,000 live births, whereas in gypsies in Rome, it's as common as 1 in 100, in 1,250 live births. So in Middle East, similarly, the incidence is as high as 1 in 2,500, and in a study done in Andhra Pradesh, it was as common as 1 in 33 births. So most of the cases are sporadic, whereas it might be familial or autodominant has also been reported. The incidence of primary congenital glaucoma is increased when the founder effect or high rate of consanguinity are found in a particular population. So coming to the clinical presentation, as we all know, the children usually present with the classical triad of epiphora, photophobia, and blepharospasm. As you can see in these pictures, that by the picture itself, you can know out that the child has the congenital glaucoma. So, however, in our in subcontinent, like the child might do not present with this classical triad, whereas they just present with simply the large size eyeball and hazy cornea. And the patient's child's family might not notice this for a very long time, and that is the cause that the child is brought to us at the very late stage. So you can see in these pictures, all the children, they have big eyes with hazy cornea, but however, they are not photophobic and they are not. There's one article published by me, my experience of primary congenital glaucoma under the children 3 years of age in our tertiary eye care center. There were 76 eyes of 46 children with primary congenital glaucoma was studied, and all the examination of this patient was done under anesthesia, where we recorded the corneal findings such as vertical and horizontal diameters, corneal hapstria, if there was corneal edema, everything was studied. We did the intraocular pressure measurement with the tonopen, and gonoscopy and ophthalmoscopy was also done. Also, surgery in all these cases, as it was a advanced case of glaucoma, so we did a trab and trab in all of these cases. Nowadays we have a latest GAT, which is gonioscopic assisted trabecular transluminal trabeculotomy, which would have been a better option, but as we are constrained, we don't have that equipment, so we just did trab and trab. And the results were like most of the children, they presented within less than 1 year of age. 80% of the children, they presented within first year of age, and mostly it was more common. 67% were male child, and 65% had bilateral disease when they present. That goes with the world literature. And there was family history of glaucoma was recorded in some patients. and consanguineous marriage was seen in 27% of the children. When the history was specifically asked, then in 27% it was history was present. So clinical features, coming to the corneal diameter, it was more around 13 millimeter on average, and the preoperative IOP was around 42.40 plus minus 8.15 standard deviations. Initial axial length was also very high, around 23, and initial club disc ratio was also high. Now coming to the clinical case series, which as you can see, this child initially presented to me with both the eyes are hazy and they look big, and subsequently the child underwent trab and trab in both of the eyes, and finally the child is doing very well. Now the child is grown up and doing very well right now. Similarly, the second case, there is a child who presented to me around 4 months of age with bilateral hazy eye, photophobia, and classical triad. As you can see, both eyes are hazy. Later on, this child underwent trab and trab in both of the eyes, and then finally the patient is doing very well. Similar, another case with unilateral congenital glaucoma, and similarly underwent trab and trab and doing very well. Similarly, third case with bilateral congenital glaucoma, who underwent trab and trab and was doing very fine with, this child did need one medication post trab and trab and is following up and doing very well. Similarly, another case with bilateral, but however one eye was very bad at the initial presentation, the left eye. Due to even doing the multiple trab and trab, we still could not get the IOP under control. So the left eye was not doing well, but the right eye was doing well subsequent on follow-up. Similarly, another child with similar unilateral congenital glaucoma, who went trab and trab and did very well. But however, these children's we need to follow up very carefully, because unilateral congenital glaucoma is more bad because the axial length in one eye is bigger, so they develop anisometropic amblyopia, so it has to be followed up very frequently and giving the correction. To conclude, I would like to say that congenital glaucoma is still a challenge to manage, because the patient usually present late and and they have to be convinced to need to go for frequent EUA, because we have to do all the examination under anesthesia. Following surgery, they have to be taken into multiple under anesthesia. And the advanced disease condition with irreversible damage are very hard to treat with, and the patient follow-up is very poor. Thank you.